Welcome to the Deep Dive, where we take your sources, your research, and our own notes, and really dig in to extract the most important knowledge and surprising facts. We want to get you well-informed, fast.
That's the goal.
Today, we're doing a deep dive into a symptom many might recognize just by looking at that yellow skin, but maybe don't understand the complexity behind it. Jaundice, or icterus.
Yes.
You shared some excellent material, and our mission today is to unpack the causes, trace those fascinating pathways, and reveal what it all means when the body's systems, well, go a bit wrong.
Think of it as a medical detective story. Your body gives the clues.
Exactly.
In this deep dive, it should give you a concise, logical, and hopefully memorable explanation. We'll cover the definition, the classifications, the actual step-by-step process, the pathogenesis, and, of course, the consequences.
So we're following the trail of bilirubin.
Precisely. We're tracing its journey, highlighting where things can go wrong, really aiming for that solid medical understanding, those key clinical insights.
Okay, let's start our detective story. What is jaundice, fundamentally? Well, you see it. It's that yellow discoloration skin, the whites of your eyes, the sclerae, even mucous membranes.
But it's more than just color.
Right. Absolutely.
Well,
that yellowing is a clear sign. It means there are increased levels of bilirubin in the blood. That specific condition is called hyperbilirubinemia.
and there's a threshold for when you actually see it.
Yeah, clinically, it usually becomes apparent when the serum bilirubin level goes above, say, about 30 micromoles per liter.
Which is quite a bit higher than normal.
Oh yes, normal levels are generally up to around 17 micromoles per liter, so it's a significant increase.
And what's fascinating is how this one visual clue, this yellowing,
It's a critical signpost. It tells us so much about what might be happening with your blood, your liver, your bile ducts. It's like a direct alert from your body.
So, to solve the mystery, we need to understand the main player, bilirubin. Where does it even come from?
Okay, so bilirubin is a bile pigment. Its main source is the breakdown of hemoglobin.
From old red blood cells. Exactly. Red blood cells have a lifespan, they get old, and the body needs to recycle them efficiently. This breakdown happens mainly in the mononuclear phagocyte system.
That sounds complex.
Think of it as the body's cleanup crew for old blood cells. Specialized cells, macrophages, mostly in the spleen, liver, and bone marrow doing the job.
Okay, cleanup crew. Got it. Now, the transformation, how does heme become bilirubin?
Right, this is where the chemistry gets interesting. So heme, that core part of hemoglobin, gets converted by an enzyme called heme oxygenase into biliverdin. Then another enzyme, biliverdin reductase, reduces biliverdin to form unconjugated bilirubin.
Unconjugated. And that has specific properties.
Very specific. This unconjugated bilirubin is lipophilic. It likes fat, and critically, it's water insoluble.
So how does it travel in the blood, which is mostly water?
Good question. It can't just float freely. It needs a ride. So it binds tightly to albumin. Albumin acts like its taxi, carrying it through the bloodstream to the liver.
The liver. Okay, the central station in this whole process. What's its main job once the bilirubin arrives?
The liver cells, the hepatocytes, they perform a crucial step called conjugation.
Conjugation.
Yeah, there's a special enzyme, UDP glycuronidase transferase, or UGT1A1. You can kind of think of it as the liver's packaging machine.
Okay.
It takes that unconjugated bilirubin and sticks glucuronic acid onto it. This creates conjugated bilirubin, sometimes called direct bilirubin.
And why is that step so vital?
Because conjugated bilirubin is water-soluble, unlike its unconjugated precursor. This change makes it ready for excretion, ready to be washed out of the body.
Right, changing it from fat-loving to water-loving so it can actually leave.
Precisely.
And its exit route. That actually gives color to some everyday things.
It does. So this water-soluble conjugated bilirubin gets secreted into bile. Bile flows into the intestine.
And then the gut bacteria get involved.
Exactly. Gut bacteria get to work. They deconjugate it and convert it into mainly two things. Stercobilin.
That's the brown color in stool?
That's the one. Gives stool its characteristic brown color. The other compound is urobilinogen. Now, some of that urobilinogen gets reabsorbed back into the blood.
A recycling loop?
Yeah, it's called the enterohepatic circulation, goes back to the liver. But the rest of the urobilinogen, it's excreted in the urine as urobilin.
And that's urine's yellow color.
That's it. It's all interconnected.
Okay, understanding that normal pathway makes it much easier to see how things can go wrong and lead to jaundice.
Definitely.
So let's move to the problems. There are three main categories, right? Plus some inherited stuff.
That's right. Three main types, and yes, some interesting inherited conditions too.
Let's start with the first one. Prehepatic jaundice, sometimes called hemolytic jaundice.
Okay. Prehepatic means the problem is before the liver, essentially. It's caused by increased bilirubin production.
Mostly from red blood cells breaking down too fast.
Exactly. Excessive hemolysis. Think conditions like hemolytic anemia.
Yeah.
Red cells are being destroyed too quickly.
So the liver's working fine, but it's just overwhelmed.
Precisely. There's such a surge of unconjugated bilirubin production that the liver, even working at full capacity, just can't conjugate it all fast enough. It gets backed up.
So lab tests would show high unconjugated bilirubin.
Correct. High unconjugated bilirubin, but typically the liver enzymes themselves would look normal because the liver cells aren't the primary issue.
Now, you mentioned this type is common in newborns. Neonatal jaundice, that's a big area.
It really is. There's physiologic jaundice, icterus neonatorum simplex, super common, affects maybe 50% of newborns.
Yeah, and that's usually okay.
Usually mild, temporary. It happens because newborns naturally have faster red blood cell turnover, so more bilirubin is made. Plus, their liver conjugation system, that UGT1A1 enzyme, is still a bit immature. It needs time to get up to speed.
But it's a more serious type in newborns.
Yes. Pathologic jaundice, or icterus neonatorum gravis, this is more concerning, often linked to hemolytic disease of the newborn.
Like Rh incompatibility.
That's a classic example. An Rh-negative mother, Rh-positive baby. Maternal antibodies cross the placenta and attack the baby's red blood cells, causing hemolysis.
And the big danger there is something called kernicterus.
Exactly. This is critical. Unlike adults, a newborn's blood-brain barrier isn't fully developed, especially in preemies.
So the bilirubin can get into the brain.
The unconjugated fat-loving bilirubin can cross into the brain tissue. It deposits in crucial areas, basal ganglia, thalamus, cerebellum. This can cause severe, permanent neurological damage. Kernicterus.
Wow. And that's linked to erythroblastosis fetalis.
Often associated, yes. That's where you see immature red blood cells, erythroblasts, in the baby's blood, because the body is trying so hard to compensate for the destruction. It's a really serious situation.
Okay, so that's prehepatic, too much bilirubin being made. What about when the liver itself is the problem? Hepatic jaundice.
Right. Hepatic jaundice results from liver cell dysfunction. Conditions like hepatitis, cirrhosis, acute liver failure, anything damaging the liver cells.
So the liver can't do its job properly. Uptake, conjugation, excretion.
Exactly. One or more of those steps are impaired because the hepatocytes are damaged.
How does that show up in tests? Is it mixed?
It's often a mixed picture. Damaged liver cells can leak some conjugated bilirubin back into the blood. At the same time, their ability to conjugate new bilirubin is reduced, so you typically see elevations in both conjugated and unconjugated bilirubin.
Plus signs of liver damage itself.
Yes, you'd expect elevated liver enzymes like AST and ALT, the transferases, those signal liver cell injury.
Okay, so we've covered too much production and liver damage. What's the third category, when things get blocked?
That's posthepatic jaundice, also called obstructive jaundice. Here, the problem is impaired bile flow. The medical term is cholestasis.
A blockage somewhere in the pipes, basically?
Essentially, yes. It can be intrahepatic cholestasis, meaning the blockage is within the tiny bile ducts inside the liver, maybe due to drugs or certain hereditary issues.
Or outside the liver.
Or extrahepatic cholestasis, that's a blockage outside the liver. Think gallstones stuck in the common bile duct, that's choledocholithesis. Or maybe tumors like bile duct cancer or pancreatic head cancer pressing on the duct.
And if bile can't flow out, what happens? What are the telltale signs? This one has some really distinct clues.
It really does. If bile can't get into the intestine, the conjugated bilirubin backs up in the liver and spills back into the bloodstream.
So labs would show high conjugated bilirubin.
Predominantly, yes. High conjugated bilirubin is a hallmark. You'd also see elevated cholestatic enzymes, alkaline phosphatase, ALP, and GGT. Those point specifically towards bile flow problems.
And the clinical signs. The pale stools.
Exactly. Alcoholic stools. They're pale or clay-colored because stercobilin isn't getting into the intestine to give them their brown color.
But the urine gets dark.
Right. Dark urine because the excess water-soluble conjugated bilirubin is being excreted by the kidneys.
What about digestion?
You can get steatorrhea, fatty stools. Bile salts are crucial for digesting fat in the intestine. If they can't get there, fat isn't absorbed properly.
And the itching.
Ah, yes, pruritus.
Yeah.
Intense itching. That's caused by the buildup of bile salts in the skin. Very uncomfortable, and a very specific clue pointing towards obstruction.
So those are the big three. What about inherited conditions? You mentioned Gilbert's syndrome.
Gilbert's is a fascinating one. It's autosomal recessive.
Meaning you need 2 copies of the gene variant.
Right, and it involves a mild deficiency of that enzyme we keep mentioning, UGT1A1. the one needed for conjugation.
So not a complete lack, just less efficient.
Exactly. It leads to mild unconjugated hyperbilirubinemia. It often only becomes noticeable during times of stress, maybe fasting, or when you're ill.
Is it serious?
Generally, no. It's considered a benign condition. Usually doesn't need any treatment. It's just something to be aware of, a variation in how someone processes bilirubin.
Good to know. Okay, as we wrap up, any final clinical points? What about subtle signs?
Well, sometimes, before full-blown jaundice, you might see subicterus.
Just the eyes.
Right, just the sclera, the whites of the eyes look yellow. It's an early or mild sign.
And just to clarify, high bilirubin doesn't always mean visible yellowing.
Correct. Hyperbilirubinemia is the high level. Jaundice is the visible sign. You need to cross that. Usually become clinically apparent. So you can have hyperbilirubinemia without jaundice.
It's a spectrum.
Exactly.
And one last time on the blood-brain barrier. Crucial difference between babies and adults.
Absolutely worth repeating. In adults, that barrier is mature. It protects the brain effectively from bilirubin. But in neonates, especially preemies, it's immature. That's the window of vulnerability, the risk of kernicterus. Huge difference.
What an incredible deep dive. We've really traced bilirubin's journey, seen how it works normally, and how things go wrong in prehepatic, hepatic, and posthepatic jaundice.
And the inherited forms like Gilbert's.
Right. It's amazing how that single symptom, the yellow color, can point to such different underlying problems depending on which type of bilirubin is high and what other clues are present.
It really is. It underlines how understanding the detailed pathophysiology, the actual mechanism, isn't just academic. It directly informs diagnosis. It connects symptoms like pale stools or itching back to that specific disrupted pathway.
It shows how interconnected everything is inside.
Absolutely. A simple color change unravels a complex story about blood, liver, and bile ducts. Makes you appreciate how intricate it all is.
Thank you for joining us for this deep dive. Until next time, keep exploring, keep learning, and stay well informed.